This is Doc Talk, brought to you by Plateau Medical Center. And now, Dr. Paul Conley.
Hello, I'm Dr. Paul Conley, and thank you for tuning in to another episode of Doc Talk. This evening we're going to continue to talk about coronavirus, COVID-19. Things have changed a little bit since our last show. We're going to talk a little bit tonight with Dr. Anita Stewart and also Dr. Scott Keffer. We're going to talk about how we're starting to reopen, and with reopening, there's some things that we have to navigate through. So first of all, we're going to get started here with mitigation strategies. So for a long time, we had stay at home, and now the words have changed to safer at home. And so when we talk about community mitigation strategies, what exactly does that mean, Dr. Stewart?
Yeah, so what community mitigation means is things that you can do to reduce your risk. And so we talk a lot about risk reduction in medicine and particularly in public health. Things like putting kids in car seats, wearing helmets when you're on bicycles, using seat belts, those types of things. Those are all considered risk reduction strategies. And so when we talk about COVID-19, it's no different. So things that we can do ourselves to help protect ourselves and our neighbors from getting COVID-19. The virus is still here. It's still in our community. So as we open up and are going into the community, we need to be mindful about things that we can do. And so examples, before we talked, there was still some uncertainty of whether us wearing masks were helpful. Or cloth face coverings. And so since our last talk, the CDC has come out with guidance, and I brought some here with me to kind of show the audience about the different types of face coverings that are available. This is a cloth face covering that my son made me during the COVID pandemic. And so this just helps to protect my secretions from infecting you. And so this is you protecting your neighbor when you wear this. And this should be worn like if you're going to the grocery store, if you're going to the bank, if you're going anywhere in public where you can't physically distance yourself more than 6 feet. We know that physically distancing is typically the best preventive measure. But if you can't do that, using a mask to help prevent transmission or face covering, that could be a scarf, a bandana, anything like that to reduce the droplets. So if you would happen to cough or sneeze, it would catch that. The second type of mask that I have here is a surgical face mask. As you can see, this is what healthcare providers would wear. We want to reserve these for the healthcare providers in our community. And the last one you guys have probably heard a lot about. This is an N95 mask. It's got 2 straps that go over the head, like this. And it's to be fit tested. I'm just going to take that off so you can hear me better. It has a tight seal. This prevents even the small viral particles from going through. This is more for the large particles. This is to prevent you from infecting your neighbor.
So, speaking of social distancing, I hope you guys, watching the show have noticed, we are actually practicing social distancing now. You may not be able to see that on the TV, but we made sure prior to the show that we're 6 feet apart. And, speaking about, these masks, you can see, I think this is something that we all carry in our pockets. We have it everywhere. Dr. Keffer, you work at the hospital. So tell us a little bit about the hospital, about wearing masks, and as far as the CDC, as far as, now what we do when we actually enter the hospital. Can you tell us a little bit about, how we proceed now where we used to be able just to kind of walk in the hospital? So what's kind of the routine that we do now going into the hospital?
Yeah, each of the healthcare providers should be masked as they walk in. Certainly there should be no one unmasked in patient care areas. But even people that work in clerical areas, in accounting, in administration, they should be wearing masks. And we feel really strongly that that is the proper way to go about this. We have the highest risk of someone coming into a place that's sick. Hospital is probably the number one because we're in a major corridor, a travel corridor from north to south and south to north. And we've always been concerned that it's going to be somebody who comes in off of 19 and sees the blue H and comes in sick, and that's how we're going to have our first contact. That's been a big concern of mine. So that anybody in the hospital really should be wearing that mask. If the patient comes in, they should be given a mask if they don't have one. to protect them and to protect others from them if they should happen to have this virus. Even if they come in with a sprained knee, it doesn't mean that they're not infected with COVID-19. They may not be exhibiting symptoms. They may not exhibit symptoms, but they may be in that phase where they just haven't yet started exhibiting symptoms. So just because you come in for a laceration on your head doesn't mean that you couldn't make somebody sick.
Right. First, just it seems like every jacket I have one of these. I have in the vehicle, and it just seems like now it's just the process. It's just kind of like putting on your shoes. I mean, now putting on your sport coat, your stethoscope. This is like part of your attire. When you go into the hospital, and we're wearing these masks. And I think, people watching the show, even like, being a proceduralist, all of our patients that come in for a procedure are wearing masks, and so that's just something that's become the new norm, as you could say it. And the N95 masks, we're still using those in endoscopy because certain procedures increase the risk of possible aerosolization of the virus. So a little bit about daily life, Dr. Stewart, at home, cleaning clothes. Like, how do you clean clothes, going out, recreational, caring for children? Just can you comment on certain things like that?
Yeah, so I think it's really important that we're, number one, using common sense with this, but number two, we have to not only be mindful of the virus, but also nurture things that's happening in our homes and families. So thinking about, making sure we're getting enough sleep, making sure that we're exercising, making sure that we're eating nutritious food to kind of keep us healthy and safe, to keep our immune system strong, and then also, monitoring our kids. And this can be pretty traumatic for kids, and we've talked about how this is what we call like an adverse childhood event, or an ACE, which could lead to problems down the road for kids. Not all households have enough food, not all households have a supportive family, and so just being mindful of that in your own home, but also thinking about your friends and neighbors and the people around you to make sure that you're checking in on others, and that you're supporting the needs and of our community as a whole. We're lucky here. We have great partners that are helping with food insecurity and providing meals and looking out for one another. So that's been a big positive for this community. But I think that we can all do our part by checking in. Other things that we can do at home, just making sure that we're wiping down surfaces with bleach solutions to minimize any viral spread. Thinking about how we recreate. So if we are going to be around others, trying to be outside, that seems to be lower risk. We have seen some spread in outdoor events, like at pool parties. We've seen spread there. So it's not no risk, but it's lower risk than indoors. And then thinking about, if you're planning a trip, like to go, it's travel season, we go to the beach or go for a getaway in the summer. Really thinking ahead about that. Look at where you're going. Look at the cases in those areas. Look at the travel path that you're planning on taking. Think about what the hospital capacity is there. These are things that we normally wouldn't do when we're making travel plans, but I think that it's really important right now that we're doing so, so we can keep ourselves and our families and our community safe.
And I think too, still, we need to talk about just the soap and water, and washing our hands. I think, we still need to make sure that we're still doing that, the 20 seconds, singing happy birthday twice, we talk about that. And I think that still, we got to make sure that we're still washing our hands. One thing, I think that's, that I've seen, is there's been a lot of stress, with this, and maybe you guys can comment a little bit about things that maybe you've seen with coping and stress. One of the shows we're going to talk about down the road is, our opioid crisis and crises with our epidemic. Have you seen, some collateral damage or maybe some issues with this pandemic?
Yes, we absolutely have. Our domestic violence calls are up from 911 center. We're looking at all those calls, so we're seeing more domestic violence. We are seeing more overdoses right now related to this. We're seeing, I think we're going to see trauma for kids during this time. I see it in patients that I see in my outpatient practice. It is really stressful, and so I think it's important that to know that you're not alone if you're feeling stressed out. This is a really stressful time. But most importantly, that if you're having any of those symptoms, like not having trouble, like having trouble sleeping, difficulty with eating, things like that, that you talk to someone about it. We have great resources here locally that can help you. Certainly call your provider. We can get you the services that you would need. But you're not alone in this. This is something that I think everyone's feeling.
So I think, one thing, churches are now starting to reopen. So I know people of faith, have really, not been able to attend church. I know they've been doing things, with, social media. But can you comment a little bit about, you folks, maybe you, Dr. Keffer, about going to church and how we can do that safely to where we can get back into, a congregation?
Yeah, I think following the guidelines is always first. And the social distancing is very important. Wearing masks is very important. Just the forceful, using a forceful voice and singing has been shown to significantly increase the risk of spread. So there's really no music a lot of times at church unless it's just a few people singing into a microphone, but no group singing just because of the risk of spread. And I think that's reasonable. I think that taping off pews and keeping people separated into their family units is important. There's still a lot of power in coming together with your brothers and sisters at church, and I think that even doing that distance, you don't have to hug, you don't have to shake hands. Mm-hmm. I think doing that at a distance of 6 feet is still better than doing it at a distance of watching through the internet or being completely separate or being in your cars in a parking lot. So I'm really happy that people are getting to go back to church, because I think that will alleviate some of the stress that people are having. People that attend church and have missed it, I think we're really suffering from that. And likewise, my little people in the nursing home, another secondary consequence of this is that they're not dying of COVID-19 virus infection, but they're dying of sadness and isolation. They have the nursing home staffs there. The staffs have been really good about setting up Zoom calls and FaceTime calls so they can interact. But it's not the same as having your family who's usually there patting you on the legs and making over you being there. And we've had dozens of deaths just in this last few months. They may have died in the next 6 months to a year, but this kind of sped the process up because they've given up. They've stopped eating. They've just stopped interacting, and we've lost them, I think, because of that.
Well, we're going to take a commercial break, and I think that's something I want to talk about when we come back is, we have had some changes with nursing homes. We are going to try to allow visitation to nursing homes, and I want both of you to talk a little bit about how we can visit these people in nursing homes and how we can go about that, and exactly what does that mean and how we can do that safely.
At Plateau Medical Center, we have the newest technology, which is robotic surgery. Prior to us getting it, you would have to travel out of the area into a larger hospital. By using the robot, less pain, quicker recovery time, quicker return to normal activities, and shorter hospital stays.
This new robotic platform allows us to do what we do and do it even better, and that's only going to benefit our patients.
It's not about the technology, it's not about the robot, it's about patient outcomes.
This is Doc Talk, brought to you by Plateau Medical Center. And now, Dr. Paul Conley.
I'm Dr. Paul Conley, and thanks for returning to Doc Talk. We're talking about COVID-19 and how we're reopening here in the area. And one of the things that we're talking about is how we can safely reopen. And we were talking about nursing homes, and these are folks that ultimately are the highest risk, but also these are folks that again that have a great need. They don't have family being able to see them for months. These people have basically felt isolated. So the governor just recently announced that we're going to open up or try to reopen visitation to nursing homes. And maybe Dr. Stewart, you can talk a little bit about the concerns we have with that and how we can try and navigate that safely.
Yeah, so we know that our nursing home population is our most vulnerable population. They typically have multiple chronic diseases, they're elderly, and we've seen in other areas of the country how devastating an outbreak in a nursing home can be and how fast that can happen. We also know that, just like we talked about earlier with stress and coping, that it is really important for their mental health and their emotional health to have families visit again. So we're at a point in West Virginia where things have kind of stabilized, we're reopening, and so we're looking at reopening nursing homes to visitation. And what that would look like would be you would have to call and schedule a visit with the long-term care facility administrator. That would be determined, like how long that would be determined by that specific nursing home. We're encouraging that to be outdoors. When you do come, you would have to have screening for temperature, screening for symptoms related to COVID-19 and travel. And certainly if you didn't pass any of those screenings, you would not be allowed to visit at that point, just to try to minimize any risk. It would be social distance. Everyone would have to wear masks. It would not include anyone under the age of 12. And again, it would adhere to the current guidelines that we have with social distancing. And so I do think that it is important. The other thing that I forgot to mention is that the nursing home itself would have to be have no cases for 14 days prior. If there were any cases within that 14 days, there would be no visitation for any member of that nursing home. If they would develop cases after that, especially if it's more than a few cases, there would be considerations of testing the facility again, and we have things in place to do that.
So I guess one of the concerns that we were talking about earlier, on the break, we're talking about symptoms, so how do we know with symptoms? And I think, since, a couple months ago we were talking about symptoms being respiratory symptoms, cough, fever, body aches, but I think now we've come to realize that that's not necessarily true, that you can be asymptomatic. So, in saying that, Dr. Keffer, I know you work at nursing homes, and so these are people that are going to be obviously asymptomatic. So can you tell us a little bit about, when someone's asymptomatic, what maybe does that mean, and if someone has symptoms, maybe we can talk a bit about that as well.
Well, obviously, if somebody has symptoms, it's easier to pick them up on screening. If they've got a fever and they're coughing their head off and they look miserable, well, they're not going to get in to visit, and that would be the easy thing. They shouldn't have even come in the first place. But that asymptomatic patient, the patients in that latent phase before they exhibit symptoms, or maybe somebody who's never going to exhibit symptoms, are the ones that worry us. But the reasons that we have guidelines in place that Dr. Stewart just went through is to prevent that asymptomatic person from transmitting virus to one of our infirm, elderly, advanced age, multiple medical problem patients. And so wearing a mask, keeping the social distance, keeping the hands clean, doing this outside, we've done everything we can to mitigate that risk. So, it's not to say that you can't be around somebody who may or may not be asymptomatic. It doesn't mean you're going to catch this if you're observing all these guidelines. It doesn't mean it's impossible that we're not saying it's impossible that you could, but we're saying that we've done the best that we can to reasonably reduce those risks. And it's just so, like I said before, the downside of this isolation has been devastating. Mothers and fathers not seeing their children, but even more importantly, wives and husbands not seeing each other, who are separated by one spouse being at home and the other being in the nursing home. And it's heartbreaking, it really is. And I'm really excited for them to be able to get to spend some time together. But I want to caution anyone who's listening that's going to be visiting a nursing home, this isn't, the doors are wide open, it's a free-for-all, everybody can come in. You're not going to be spending the whole day sitting in the room with mommy taking meals. It's not going to be that way. And I don't know that we'll get back to the old days anytime soon, if ever, because there's just too much risk. This, like Dr. Conley said, this comes into one of the nursing homes, it can spread like wildfire before we can ever think about containing it. We've got everything in place to try to do that, but it's impossible to protect everyone once this starts. So please just be reasonable, be understanding. If you're going to want to visit the nursing home, know that you may not get in on the day that you want to. You know, if you're traveling from somewhere else to see someone in a nursing home, make those arrangements ahead of time. Don't show up and say, I've come from Pennsylvania to see mom. Well, not Pennsylvania, that's a bad example because I don't know if we're letting out-of-state visitors come anyway. But I've come 4 hours from across the state to see my mom. Why can't I see her today? Be reasonable. You know, try to follow the guidelines. Talk to the administrators. Talk to the staff at the nursing homes. Try to make this a seamless and happy occasion rather than something that's stressful and makes everyone sad.
And I think that's one of the reasons why we want to talk about this show, because I think from this last show to this show, there's definitely been COVID fatigue.
Yes.
I mean, I think what happens, we get desensitized, and our concerns we talked about at the break was like a surge, and it seems like the number of deaths in this country changes and continues to go up as we open more things up. And I think that's a concern. And I think one of the things we talked a little bit about a couple months ago was how we test and the type of test. And since that show, things have changed a little bit about testing. And so I guess, Dr. Stewart, when should someone get a test? And can you tell us a little bit about the type of tests that are currently available?
Yeah, those are great questions to cover because they have changed quite a lot. Before it was you had to have symptoms, you had to be a healthcare provider or work in congregate care settings to get a test. Now the tests are more widely available here. And so really anyone that feels that they need to be tested can be tested per CDC guidance. It would be of utmost importance if you're having any of the symptoms that we've talked about related to COVID-19 that you would get a COVID-19 test. If you're a healthcare provider, work in congregate care settings, or working with a vulnerable population, we would want you to be tested if you are having any symptoms related to that. But again, to know kind of how things are in the community, if you just want to know what your status is, you can get a test. The testing that I'm talking about right now is a PCR test, which is the diagnostic testing for COVID-19. Initially, when we started, it was the long swab. We so lovingly refer to it, or the patients refer to it as the brain biopsy. It goes back into the posterior nasopharynx to get some of the secretions. Those sampling methods have also changed since our last talk. Now it's as simple as even just to swab around the 3 times around the inside of the nostril on both sides, so it just feels kind of tickly. It doesn't hurt. I've swabbed several kids. They've done great with this, so it's not anything to be scared about. So please don't let the test scare you away from getting a medical procedure that you might need, getting tested for symptoms that you're having. Don't be afraid of the test anymore. It is not as scary. The other type of test that's available is a serum antibody test, and that tests to see if you've potentially had the infection, if you've mounted an immunological or antibody response to that. We currently don't know what that means for COVID-19. We can kind of extrapolate from other infections that it could provide some protection. When we've looked at other SARS infections, it seems to give about a year or two of coverage for that, but we're still very early in the process. One thing that I would say in regards to like the reliability of those tests, they are very good tests in areas that have high prevalence. So like New York, places like Seattle that have had higher incidence of disease, those tests, because the pretest probability or the positive predictive value of that test depends on prevalence. And so if your prevalence is higher, the test, if it's positive, is going to be more likely positive. In West Virginia, we've been blessed that we've had a lower prevalence. It's been one of the best in the nation. And so when we look at doing the antibody test, because our prevalence is so much lower, if we have a positive, it's most likely a false positive. We would recommend anyone that has a false or has a positive antibody test, if they're having symptoms or if they have a contact that was positive, that we would do also a diagnostic PCR test related to that.
So I'm really glad to hear that the testing's changed somewhat, because currently our practice and a lot of hospitals, coming in for a procedure, with my work, with doing endoscopy, we make sure these people have a test. And some of the folks who have been tested prior, are really reluctant to get tested again because the test they had was again very, very uncomfortable, to say the least, and they just don't want to repeat that. We want to make sure these people are getting the tests they need, and that they're not having an underlying malignancy or whatever, and they don't get the tests they need because of the uncomfortable experience they had before. So these newer swabs, I think that's important that folks know that. One thing that we were talking about, before at the break, we're talking about when is this going to end? Like when is COVID going to go away? And I know you guys get that question every single day. I know I do. When is this going to cease? Because I think everyone's ready to cross that finish line. And so we talked a little bit about vaccine, that vaccine therapy, which, we talked about warp speed. Food and Drug Administration has allowed that to go quicker. FDA is usually pretty conservative unless it's like a cancer drug, because we know cancer is something that's fatal, so they make exceptions. In this situation, they're making an exception, right? I mean, they're making an exception with trying to advance it. So maybe, you guys both, can kind of chime in. You first, Dr. Stewart, a little bit about where we are with vaccines and the phases of vaccines, safety of the vaccines, and their effectiveness.
Yeah, so the way we develop vaccines as medical professionals is, and scientists, there's 3 different phases. So there's phase 1, phase 2, and phase 3. And each phase has increasing number of people in those trials. Phase 1 and phase 2 are based on the safety of the vaccine. So is it safe? Phase 3 is more about how effective is that vaccine. They're also looking at effectiveness in the first 2 stages, but the main focus is for safety. There's about 160 vaccines currently trying to be developed for COVID-19. But right now, it looks like there's probably 5 or 6 leaders in that, and that are currently doing phase 1 and 2, and will be starting phase 3 in July. So it's very promising. I do think they're going to do it in a safe manner. I think that they'll be able to manufacture the vaccine very quickly. There'll be lots of monies being poured into that whenever we find that they are effective and safe. So I am quite hopeful for that, and then it will determine, how do we distribute those vaccines.
So I guess one of the questions that I have, let's say maybe Dr. Keffer, is the the immunity and how long does that immunity last with the vaccine. I think you work in nursing homes, so I know it's important that you make sure these nursing home patients receive vaccines like influenza vaccine, shingles vaccine, what have you. So I think maybe you can talk just briefly about what is the effectiveness of a vaccine, and is 100% if you do receive the vaccine?
Well, there's no vaccine that's 100%, to my knowledge. There are people that refuse vaccines every day, so obviously it's not effective to them. And there are people that take vaccines that are not effective for them. There are vaccines that are made to cover particular strains of, say, influenza, and they miss that guess. And there are strains of influenza that show up that year that aren't covered, and everyone who took the vaccine is not protected. So, I mean, vaccines are an inexact science. It's the best that we have for situations like this. My dad's family was quarantined with polio when he was growing up, and that polio vaccine was a godsend for them, because I can remember my grandparents talking about having a big fight because they picked up a hitchhiker when there was a polio outbreak, and my grandmother was convinced that my grandfather picking up somebody on the side of the road was going to give all the kids polio. So I mean, vaccines through the years have been such a relief for people. And it's been such an interesting situation hearing about vaccines in the last 4 or 5 years. I think it's going to be interesting to see how that changes, that conversation changes once we get a vaccine for COVID-19 that's caused such a disruption in all of our lives and our businesses, and and certainly in the lives of people who have lost loved ones or lost their own lives. So I'm hopeful that the narrative about vaccines can change some. There has to be a certain level of trust in your provider, in the federal government, and overseeing these things. And trust is something that's in short supply in the world we're living in right now. And I'm hopeful that we can get a vaccine that will rebuild some of that trust. We have people speaking as though they're epidemiologists all over social media. Epidemiologists aren't speaking in absolute terms. The world-renowned physicians don't have declarative statements. there are a lot of ifs. There are a lot of we're trying to figure this out. So anybody that you hear speaking definitively on social media is probably wrong, and it's probably misleading you or causing some anxiety and guilt or frustration that none of us need. As physicians, I always say we look back every 8 to 10 years and realize about 20% of what we were very certain of was wrong. And with this COVID-19 situation, that's shortened. It's not 8 to 10 years; it's about 8 to 10 days. We look back and go, "Oh boy, we were wrong about that," and that's the best that we had at the time. So I think the patience that the American public has shown overall has been exemplary, especially here in the state of West Virginia, and I'm proud that we have done such a good job, that we've kept our numbers low, that we've kept our hospital in Oak Hill, West Virginia, free from even a single case of COVID-19. And that's really a testimony to people being willing to put their lives on hold to be safe, to make changes in their lives, to really embrace the safety of their families and themselves and their communities. So it's
Well, I really appreciate you guys coming, and we're running out of time. And, I want you guys to understand, Dr. Stewart and Dr. Keffer, how much I appreciate you, Dr. Keffer, being a hospitalist, being on the front lines. Dr. Stewart, you're on the front lines, as the, health officer here in the county. I just want you folks to understand that, that this show is always open for you folks, because I know that it's going to change. And so I want to have you guys back again. I do hope that people watching this show understand we still need a social distance, which we are doing here in the studio today. We have our masks in our pockets. When we go out, we're wearing our mask, because that's what's going to make a difference. Is making sure that we continue to adhere to these practices of hand washing, what have you. Because the vaccine, even though as good as that may be, is still not going to be here tomorrow. And so we need to make sure as we reopen things that we do it in a smart way, because we've all know that all it takes is just like one person that can infect, and we talk about that R number that can affect 3, which it becomes 9, which becomes, so I think that's important. So again, I appreciate Dr. Keffer, Dr. Stewart for coming on the show. This has been another episode of Doc Talk, and until next time, have a good night.